Good afternoon and welcome. My name is Lucy Aquino and you are watching a live interactive show brought to you by Can Cable 21. And for the next 45 minutes, we're going to be discussing breast health, mammograms, and what you need to know. We invite you to call in with your questions. The lines are now open and the number is at the bottom of your screen. Area code 312-738-1060. Our phone lines are now open. With me today is Dr. Kevin Kirshenbaum, Section Chief of Breast Imaging with Advocate, Illinois Masonic Medical Center. Allow me to welcome you to the show. Thank you for being on the show today.
Thank you. A pleasure to be here.
Well, this is wonderful. I mean, the topic of mammography, breast health, imaging, 3D, and so many other things that are happening with new technologies is just totally amazing. But at the same time, there's also controversies, conversations that need to be had, and who knows how to answer those questions because there's just so many questions to be had. But Dr. Kirshenbaum, the U.S. Preventative Service Task Force, an expert group that reviews the latest research findings, recommends that mammography screenings for most women start at the age of 50 rather than 40. And that the frequency be every 2 years instead of annually through the age of 74. However, the American Cancer Society strongly disagrees and is still recommending annual mammograms for women over the age of 40. Doctor, what do you say about that?
So this is interesting. There's a long history behind different groups, and whether that's the American College of Radiology, the American Cancer Society, the American College of Family Practitioners. What's most important is all societies agree that mammograms save lives, to the order of 1 to 2% per year since 1990. No one would suggest that we do away with mammograms. No one would suggest that it's not important for women to undergo mammograms. The real argument is really one that happens all the time within the scientific literature. It just happens to be within breast imaging that's played out in the press. And so you need to discuss with your physicians and your individual physicians. What's most important, as I said, there has been a significant reduction in mortality for breast carcinoma related to breast imaging and specifically mammography. And so whether it's every year or every other year, we'll probably get in a little later in the discussion with regards to some of the newer imaging techniques, some of the newer screening studies with regards to the detection of breast cancer. But for now, it's every year, annual screening, starting at the age of 40. And really up till, while the guidelines certainly call for the age of 74, that age is shifting as we speak. And so it's really a discussion as you reach your 70s to discuss with your doctor, should I be screening every year? Should I be screening every other year? I can speak for the American College of Radiology. I'll speak for myself. And that is, it's probably misconstrued that we should be advising women in their 40s to have screening mammograms every other year as opposed to every year. Young women, when they're in their 40s, certainly in their 50s, they have dense breasts. It's harder to see cancers on those pictures. And so overall, those are the women that should be screened every year, and that's a strong recommendation for the American College of Radiology. Maybe it's a discussion to have, frankly, with regards to patients over the age of 70. Should those women have screening mammograms every year? That's a discussion to have, and it's a discussion to have with your doctor. I think the take-home point is to have annual screening mammograms. And
that's that very important discussion, is where we're talking a little earlier, is that because you turn 74 doesn't mean you stop taking care of yourself. So you are expecting that there be some change in the near future. And how near do you think that's coming?
So we're at a crossroads, frankly, within breast imaging, and it's extremely exciting, frankly, as the director of breast imaging, as someone who's devoted a large portion of his professional career. Again, a little bit of history. We screen women in the United States for the last 20 years, and we suggest that every woman is treated the same. They're getting an annual screening mammogram. That is changing. It's changing on the basis of really two issues. Number one, breast density. So to get a little into the specifics with regards to breast density, half the women in the United States have dense breasts on their mammogram. In and of itself, not a big deal. It does raise your risk factor for getting breast cancer a little more than the average, number one. And number two, it makes it harder to read regular mammograms if you have dense breasts. I liken it to taking a look at a mountain, frankly. There are some Mount Hood, for example. My family just went out to Oregon. You go to Mount Hood. Mount Hood has an awful lot of snow on it. And if I'm looking for a snowball on Mount Hood with a lot of snow, it's going to be pretty difficult to take a look and find where that snowball is. On the other hand, about 2 hours east along the Oregon coast, they have these series of haystacks that don't have a single bit of snow. It's nice and warm weather there, which is amazing. If I'm looking for a snowball on a mountain that doesn't have any snow on it, I'm going to see it pretty easily. And that effectively is the difference. If you have fatty or not particularly dense breasts, it's easier to find cancers, number one. And number two, you're less likely to develop cancer to begin with. And so overall, when you take a look at breast density, that's the first factor that we'll be talking about. And number two would be your risk factor. Not everyone has the same amount of risk. So the average risk population has average risk, but there are genetic factors that sometimes come into play. BRCA1, BRCA2, for example. These are genetic dispositions, frankly, that some women have, that they have an increased risk of breast cancer. And so based on risk and based on density, those patients will, going forward, and I'm saying going forward, working within the next year or two, will be offered other sorts of screening modalities. So for example, a dense-breasted woman will be offered whole breast screening ultrasound. There's significant evidence in the literature to suggest that screening with ultrasound may benefit those women to the order almost of the same amount of cancer detection as mammograms. There's 3D imaging, digital breast tomosynthesis. This is another technology that you're probably hearing about that also has some extra added benefits with regards to dense breasts, even non-dense breasts as well. MRI, particularly within a high-risk population that have dense breasts. So we're in a very, very exciting time. It may not be as straightforward. It may not be just boiled down to one sentence, which means just get your annual screening mammogram.
Right.
So it may be a little more complicated than that, but it's upon us as a society to really have that discussion. For you individuals, for women to have those discussions with their doctors, as well as with their radiologists.
Well, being that there's going to be so many options, and there are a few now, is that something the physician determines to do as to the type of exam or screening? Or is it something that a patient, woman, can come in and say, I would prefer not to have a mammogram, but prefer to have a 3D? Is that her option? And if she knew enough about it, that she can go in and actually request that? Or does that come from the doc?
No, I think it's a combination. Like I said, we're at a bit of a crossroads. So I think there's education to be done on all sides. And frankly, this happens to be my area of expertise is breast imaging. The average family practitioner and internist has an awful lot to keep track of. It's upon us as a radiology group to educate individual docs with regards to what are appropriate for their patients. I always say that the captain of the ship is the patient, and so the patients themselves need to keep up to date. They need to Google. They need to take a look at the literature. And then any questions that they have, they need to run that through their individual docs, because as we know, there's an awful lot on Google and on the internet that sometimes applies and sometimes doesn't. Again, what's most important, the take-home point, I wouldn't want anybody walking away saying, oh, we're at a crossroads, maybe mammograms can be thrown away. Mammograms at this point are tried and true. They are really the workhorse of an imaging to be able to detect breast cancer early. There are other modalities. And in fact, the state of Illinois, as well as a number of states throughout the country, have passed legislation that really just applies this year. If anybody's had a mammogram this year, if you have dense breasts, we, by law, radiologists, that radiology report, the letter that goes out to you, will have a paragraph that states, do you have dense breasts or not? And on the basis of that, you would have a conversation with your physician with regards to what are the additional steps that go forward. It really is. It's a question to take a look at, number one, risk factors. Should I be tested? Number one. And number two, if you decide not to be tested, if you have dense breasts, we now have the ability, we have another imaging modality, frankly, that's whole breast screening ultrasound, which we know can detect a breast cancer over and above mammograms. These are cancers that were heretofore not seen on a mammogram. I can give you my personal at Illinois Masonic, as well as at Good Shepherd up in Barrington. We have detected a combination of 13 new cancers within the last 12 months that were not detected on the basis of a mammogram, meaning the mammogram was normal, and the ultrasound was abnormal, and in fact we detected very early cancers, and the women have done well.
Wow.
So it's extremely, extremely exciting, but most important is you don't really abandon mammography in favor of another technology. It's mammography, and then the question is, do you add another screening modality to that?
So always start with the mammography, obviously. So if a woman finds a lump on her breast, the mammogram, and what you're saying is still very important.
For sure. I mean, certainly if you were, for now we've been talking about, or I've been talking about, screening a non-symptomatic woman. If you have a lump, if you have focal pain, these are things that are going to be worked up differently.
Right.
And for now, that's what nobody would question a mammogram and an ultrasound in those cases.
You mentioned earlier women who carry the genetic mutation of BRCA. Can you talk a little bit about that?
Sure. So there's a number of different genetic predispositions. Those are the most those are the most common. So BRCA1 and BRCA2. To stress, the majority of breast cancer that occurs in this country has nothing to do with genetic predisposition. So whether you have a genetic predisposition, if you have it, it does raise your chances of developing cancer. So on the basis of that, what else would you do if you have a greater predisposition to breast cancer as opposed to the general population? And we've talked about that a little bit. We now have options. We have whole breast screening ultrasound, and we have breast MRI. It is the American College of Radiology, the American Cancer Society, and the American College of Surgery would agree that patients that have dense breasts that have a genetic predisposition would undergo MRI. And MRI is without compression. It is a contrast examination, and it is a highly, highly sensitive examination.
Doctor, with not just BRCA and genetic mutations, but we're hearing a lot most recently too about genetic testing. Is that something that women can also request from their physicians, or is it based on family history?
So it's really a combination. Again, this is a discussion that must take place with your primary care physician, whether that's your internist, your family practitioner, your OB-GYN. If you have a positive family history, it doesn't necessarily mean that you have the gene, that you have the BRCA gene. And so if you have significant family history, it's a discussion that you'll have with your doctor. If you don't have any significant family history, but you develop breast cancer, then your family members, and it's whether it's your sisters, whether it's your mother, whether it's your daughter, then that's also a discussion that needs to be had with your doctor.
I do want to remind our viewers that with me today is Dr. Kevin Kirshenbaum, radiologist, as well as section chief for Imaging Center at Advocate, Illinois, Masonic Medical Center. And our topic today is obviously mammograms, breast health, and what you need to know. If you have any questions for us, please pick up the phone. Give us a call. The number's at the bottom of your screen. Area code 312-738-1060. The lines are open. So, Doctor, can you tell me why, with all this discussion that's being had and all these new ideas as to what should be done, what shouldn't be done, there are a lot of medical groups and a lot of groups who disagree to agree or agree to disagree? Which is it?
Yeah, so that's the million-dollar question. If I had an answer that could be boiled down to a 30-second response, I'd be probably a rich person. So to get a little bit into the weeds, into the details, there is mammograms, breast imaging, any sort of a screening examination has its upsides and has its downsides. It's a cost-benefit analysis, frankly. The upside with mammography, most people and most societies would agree. There's overall cancer mortality reduction with regards to the screening study of mammograms. But that comes at a cost. So it comes at a real cost, a dollar cost, and we as a society can take a look at what is the average dollar cost for the saving of a life with regards to breast cancer. I can tell you that the most latest data would be that for every year life saved with regards to breast cancer mortality reduction, that's about $18,000. And I know that's a difficult thing to talk about, but it's $18,000. But we also spend $700,000 per year life saved for seatbelts. I don't think anybody would suggest that we eliminate the use of seatbelts in this country.
Right.
And for the same reason, I wouldn't suggest, and I don't think anyone would suggest, frankly, that we wouldn't use this valuable resource that we have, especially when you see significant cancer, breast cancer-related mortality reduction in the United States. So what is the downside, frankly, other than cost, other than money? Well, for every screening examination, I can tell you that every time I see an abnormality, I have to call that patient back. So for every 100 screening mammograms I do, if I'm a radiologist that's doing well, that's practicing according to guidelines and benchmarks throughout the country, then you're going to be called back about 10% of the time. That means 1 out of every 10 women, when you have a screening mammogram, will get a call and say, we need you to come back, we need some extra views. Now, the huge majority of those patients will turn out to be normal on those additional views. Or they'll have something that I would liken to, let's say, a mole or a freckle that a skin doctor would see on your skin, and they would say, why don't you come back in 6 months to make sure that area doesn't change? And that's what we're doing. On the other hand, when we're doing that, that raises a tremendous amount of psychological pressure on the woman when you get called back in. And frankly, when you come back in 6 months later, as far out as 2 years, to make sure that area doesn't change. So there's a psychological impact. There's a cost impact on those additional studies that are done. If I see an abnormality and I consider that suspicious enough where I'm recommending a biopsy, if I'm doing a good job, again, as a radiologist from a national benchmark perspective, I would say on the order of 60 to 70% of the time, that's going to turn out to be a benign growth, non-cancer. That means only 30% of the time, when I see something suspicious enough where I'm recommending a biopsy, does it turn out to be cancer. Now, that's obviously a good thing.
Right.
On the other hand, it tells you that there's limitations to the technology. There's limitations to the regular mammogram in that we're detecting things, a lot of things that are not cancer, and we're detecting a lot of abnormalities that we're suggesting a biopsy on that turn out to be benign, with its respective costs and its respective psychological impact. And so that's where some of the societies are pushing back. They're saying, is the downside worth the mortality reduction with regards to mammography? Again, the mortality reduction is pretty clear. It's about a 25% mortality reduction. Most societies would agree with that. I think it's a nuanced conversation, and that's why I led earlier in the discussion with regards to an educated patient. There's nothing better than an educated patient who comes in and who says, look, I understand the risks and benefits, and I'm choosing to undergo mammography.
Right. It's really interesting because as we talk about education, and I'm sure you recollect this, a few years ago, there was that scare about that women were being told they should not get mammograms and they could only get them. Things were changing. They were told, I believe it was every 2 to 3 years. Through the Latino community, that was such a scare, but at the same time, very, very confusing. So being educated and knowing what to do and when to start. So for the purposes and for our viewers' sake, can you tell us once again, when should a woman start with her first mammogram? At what age?
So with absolutely no family history, that's an average risk population. The average woman should start at the age of 40 and have yearly mammograms after that. And that's a reflection not of only my own view. That's of, again, the American Cancer Society, the American College of Radiology, the American College of Surgeons.
And definitely because it's a preventative screening, most insurances will cover it.
Oh, yes. Yes.
Which brings me to, now I've heard most recently, I did not know this, but that you can actually schedule a mammogram with an imaging center without a physician's order. Is that correct?
That is correct.
Right.
Depending on your provider, but certainly Advocate, that has been a major push with an Advocate for the last, I would say, 1.5 to 2 years. And so, yes, it allows access, frankly. It doesn't allow so many hoops to be able to roll through to be able to get, a very, very valuable screening examination. And so it allows for same day. Critical to that is that you need to have a physician that the report will be generated to so that there can be appropriate follow-up.
Absolutely. Well, that's good to know that the access is there. Doctor, we talked a little bit about the different types of screenings. 3D was one of those. And women having a choice of a 3D or women who want a mammogram, obviously. But if someone was to be offered a 3D and they were to decline it, why would they decline it?
So I think that
What do
gets
you
into
think?
that gets into the whole discussion of 3D versus 2D, right? Fancy terms. Are we talking about some sort of Nintendo, some sort of internet-based sort of games?
Right.
So let's at least first talk a little bit about 2D versus 3D
Okay.
mammograms, and then how a woman, again, an
Absolutely.
educated woman, would be able to make that decision. So a mammogram is a 2D depiction. It's effectively a piece of film, paper, or it's a monitor at this point, that depicts a three-dimensional object, the breast. 3D begins to get around that. The limitations of the regular 2D, when we say 2D, that's the regular mammograms that have been performed for the last 20, 30 years. The limitation to that is that because it's a paper-thin depiction, you're superimposing an entire thickness of breast. And as women can tell me far more than I can tell them, that compression, that hurts. And so the ability to be able to see through that thickness of breast on a two-dimensional object, we're superimposing a lot of anatomy there. So the entire thickness of the breast effectively is being depicted on a single picture. 3D allows effectively for slices to be performed through that thickness. It's effectively taking a look at a slice of bread. The analogy breaks down, but if I was trying to look for a caraway seed within a rye bread, I would really rather take slices, and as thin as slices as I possibly could, were to be able to run into that caraway seed. On the other hand, if I really wasn't able to, I was just kind of looking through some of the cracks with regards to the outer portion of the bread, it would be more difficult to take a look for those caraway seeds. And that's really what we're doing. 3D technology, which again is relatively new, but it seems to be within the literature, early literature, but within the literature, there is the ability to be able to detect additional cancers over and above the 2D mammogram based on those series of slices. So, what are the, again, upsides and downsides?
Right.
I've just listed the upsides.
Right.
The downsides that historically, with digital or 3D imaging, that was associated with an increased amount of radiation. The increased amount of radiation is very similar, frankly, to how mammograms were done 20 years ago. But if you're comparing a mammogram that you probably had a digital mammogram if you were at an accredited center, is probably a little more than the 3D has more radiation than the 2D one. On the other hand, if you take a look at the most recent data with regards to 3D imaging, the 3D imaging now that they're performing is pretty comparable to the amount of radiation that you get for a general mammogram. And so overall, there really is no downside to having a 3D mammogram over a 2D mammogram. Also the additional upside, and this is a significant upside, is that when I talked about on a regular mammogram, 10% of patients being called back for an abnormality, that callback rate reduces by about 2 to 3%, meaning I'll call back instead of 10 women or 1 out of every 10, I'll call back, let's say, 7 out of 100 patients.
Wow.
And that is based on that lack of superimposition, those ability to take a look at those individual slices and to be able to say, hey, I guess that wasn't an abnormality, that was normal breast tissue that was superimposed on it.
Wow, those are huge numbers, though.
Yep.
Very, very, very impressive. Now, we've also heard that myth that doing, taking a flight, taking a trip across the country, or a 2 or 3 hour flight, you get more radiation on an airplane than you do doing a mammogram. Is that true? That's
pretty true. It is a small amount of radiation. So again, this is not something that I talked about, risk versus benefit.
Right.
I think you have to have a pretty honest conversation. You can't say that the risk is zero with regards to radiation. I can tell you that the majority of the studies that have come out with regards to cancer induction, meaning what cancers begin or what cancers are induced by radiation, are frankly extrapolated from studies from Nagasaki and Hiroshima. And so these are very, very intense sorts of exposures to radiation. With a minimum amount of radiation that's associated with a mammogram, it is as if you got the same amount of radiation living 3 days in Denver, Colorado, being higher to the sun on a mountain than you would down here in Chicago.
Wow.
And so is it zero? Is the risk of inducing a cancer related to mammography zero? No, but it's somewhere on the order of 1 in 2 million or 1 in 3 million. And again, that's extrapolated from studies. Nobody would be able to say that that's indeed the case. But for the number of cancers that you detect, which again, we said anywhere between 4 and 8 cancers per 1,000, and the number of cancers that theoretically, the 1 in 2 million to 1 in 3 million, that it would potentially induce, I think the math is pretty clear.
Oh. Doctor, with these new images, and this type of new technology, are the images obtained differently?
No. So you wouldn't. It's kind of like the Wizard of Oz. That what happens behind the curtain, it happens behind the curtain.
Okay.
Overall, the machine itself will look the same.
Mm-hmm.
You will be in compression, and the tube will not necessarily stay stationary where you're used to that. The top of the tube, whether you're looking or not with your eyes,
Right.
that tube will move a little bit. But overall, the time of exposure a little more. Let's say 1 to 2 seconds, but nothing that you would really be able to detect at this point.
Oh. But yeah, it's better technology. And as we talk about technology, with the manufacturers delivering and developing these new technologies, the equipment, do you think as time goes on, will the radiation actually be less exposure? Or will there be, I mean, the idea is here is to get as less as possible. So with new technologies, do you foresee that in the future?
Right, I do. I really am personally extremely excited about whole breast screening ultrasound. I do believe
what
as
is
we
it? Yeah.
whole breast screening ultrasound.
Yeah.
Ultrasound. I'm sure many women in the audience have had some sort of exposure to ultrasound. Right, ultrasound, which is used in gynae in taking a look at fetuses. Ultrasound has been used for all kinds of different applications for your gallbladder, for your pelvis, and it has certainly been used for breast imaging. But it has only really been used for breast imaging with regards to whether you have something that you feel in the breast, a focal area of pain. That's where we would historically have applied breast, as well as an abnormality that we see on a mammogram. Oftentimes we'll see that abnormality and we'll have you come back for additional pictures, meaning on a mammogram, but we'll also have you undergo an ultrasound to see whether if we're seeing some sort of a mass, some sort of abnormality, is that fluid filled, is that a cyst that you can completely ignore and it's completely benign, or possibly something different. So ultrasound has been used for an awfully long time on all kinds of different applications, including breast. Most recently, it has been used as an application as a screening study for breast cancer. This was the Akron 6666 trial, which was a multi-institutional trial, talking about whole breast screening ultrasound and the ability to detect breast cancer, particularly through dense breasts. Since that time, the state of Connecticut, their legislature passed legislation which mandated them to offer whole breast screening ultrasound. That data was looked at for a 2-year period of time back in 2011 and 2012 and found additional over and above mammography detection of cancer on the order of 3 to 4.5 cancers per 1,000 screened. And again, remember what I said earlier, that general mammograms in the routine population detect anywhere between 4 to 5 cancers per 1,000. And so we're talking about almost doubling the potential for cancer detection. This has its upsides and it has the same amount of downsides as I talked about, in the same way that it will detect things that turn out to not be cancer, in the same way that I'll be recommending biopsies oftentimes that turn out to be benign, non-cancerous. So both imaging modalities are extremely valuable. I wouldn't want anyone to walk away saying, oh, I don't have to have my mammograms anymore. Dr. Kirshenbaum said I can just go ahead and have whole breast screening ultrasound, which is warm gel and just having a nice probe placed over the breast and no pain at all.
Right.
That is true. That is the advantage, frankly, with ultrasound. It also, the advantage for ultrasound is there is no radiation. On the other hand, my strong suggestion would be this with regards to mammograms. They are painful. I personally haven't undergone one. My wife, my mother, my mother-in-law, series of women in my life had described to me the pain. If it comes to the point, as I've said earlier, the individual is the captain. And so they need to have a conversation when they walk into the room with their technologist as to what they can tolerate. Obviously, the technologist, as well as the radiologist, is trying to come up with the absolute clearest picture. The clearest picture would be the greatest amount of compression. On the other hand, if that causes so much pain that that woman walks away and says, I'm never doing that again, then we clearly have shot ourselves in the foot and done a disservice to the patient. And so it really is a discussion. It's an again, as I've said, it's an educated patient who needs to walk in and have that conversation with the breast imaging center, no matter where they go, to be able to optimally handle that study.
Absolutely. And you hear that a lot too. I mean, we see community events or women, as we're talking about breast health and prevention, is that a lot of women will say, hey, I had a mammogram 10 years ago, but I'll never do it again. And, it hurt so much, and they weren't sensitive to what it was that I was feeling, and I was expressing my concern and things like that. So it's definitely something that is Dr. Kirshenbaum is saying, you are the captain, and it's up to you to make sure you say something to that technologist and make sure that that tech knows how you're feeling, and why you don't want to continue, or better yet, even though you tolerate it, but don't let it change your mind about going back and having it done. Don't let so many years go by that it doesn't happen.
Well said. Well said.
So, doctor, if you can leave our audience or guide them through some wonderful wisdom, what would you tell women?
I would say that you need to know as much about yourself and with regards to your breast health as you possibly can. And that starts with, if you've had a mammogram at the age of 40, you would then be able to either request, if you've got a letter, certainly you'll know about it, whether you have dense breasts or not, or you can inquire, frankly. You can ask your doctor, you can ask your radiologist, frankly, if you land in the breast imaging center, and asking them, indeed, what is the density of my breast? That will begin to educate you with regards to what are the sorts of modalities, what are the sort of screening studies that I can be using. Number two is to really educate yourself with regards to risk, taking a look at your family history and having that discussion with your individual physician with regards to, number one, is that family history significant? Most family history is significant. If it's a great-great-great-great-grandmother, that's less significant than if it's your mother. So that's a discussion, frankly, to have. And there are tests, frankly, not only tests, not BRCA1, I'm not talking about genetic testing, but actual risk modeling. Frankly, there's a Tyrer-Cuzick, there's other models that are frankly being offered. So that's, again, sometimes they're being offered in the breast center because it's a convenient location. Other times you should be asking your physician with regards to, again, risk modeling. Once you have those two pieces of information, then it's really a question of having a discussion with your doctor and you going, frankly, online and educating yourself, as we've said, with regards to 2D breast imaging, which is the regular routine mammography, which pretty much everybody says, as we've said, is annual screening starting at the age of 40. 3D imaging, which will be coming online. We're certainly getting that at Masonic. We're getting that throughout Advocate. There's a commitment throughout Advocate to get it at every site. But we are on the cusp. Not every breast imaging center, and there are very high-quality breast imaging centers, they don't have 3D imaging, frankly. So that's something to be educated about. Finally, whole breast screening ultrasound, to understand the concept of breast density, what that means, and that there's another breast screening tool out there that's over and above mammography, not instead of mammography, but over and above.
Right.
And then finally, MRI. MRI, an expensive test without question, but certainly insurance covers with regards to patients that have dense breasts and a positive family history or an increased risk of breast cancer based on those modeling. So that's really it. We're really talking about similar things, and that is education. It's really education.
Now, you mentioned modeling. Can you talk a little bit about that when you're saying, for our viewers who don't understand the lingo, what exactly are you saying by that?
Sure. There are Hughes models. These are just people's names that have attached themselves to a series of surveys. These surveys you would fill out, again, that could be in your doctor's office, they can be in the breast imaging center. Based on the answers to those studies, which will talk about what age you were when you had your first period, when you went through menopause, how many kids have you had, how old were you when you had your kids, is there any family history of breast cancer, a series of things that would go into this survey effectively and come out, frankly, with a number. It comes out with a risk model, a risk number over and above the general population. If that exceeds, and again, depending on the model, that will change, but if you have a 20% increased risk over and above the population based on these series of factors that I just described, and some. I'm not even sure that I could come up with all the different factors that you'll be asked. On the basis of that, if you're found to have increased risk over and above the general population, that's a piece of information, a very valuable piece of information to have with regards to, well, maybe I should screen myself more intensely. Maybe I should undergo a whole breast screening ultrasound maybe I should undergo an MRI. And so again, that not only breast density, which is something that you certainly, it's going to come out one way or the other, whether you have any sort of a mammogram, we'll see. Every mammogram comes with a report of density. But the risk, your overall risk in comparison to the general population, is a critical piece of information, and we're just beginning to see that. Just beginning to see that as a priority, frankly, with regards to women's health.
Wow. So I did want to share this with our viewers. For any viewer needing or wanting more information about mammography or any of the other things that we've talked about today, please give Diagnostic Imaging at Advocate Illinois Masonic a call. Their number is 773-296-3000. They're located on the corner of Hosted and Wellington on the north side of Chicago. Again, this number is 773-296-3000. Should you want more information, please give them a call. I'm sure they'll be more than happy to answer any of your questions, maybe even help you find out whether or not your insurance covers it and what they're willing to cover, or have that discussion with your physician. I'm sure your physician's office can do the same, and find out whether or not MRI, 3D, 2D, ultrasound, what's being covered, what's not being covered. Doctor, our time here goes by really quickly, and I know that we can keep talking about all these new things that are happening, but it's really important that we educate. And I'm going to remember your phrase. You are the captain of the ship.
There you go.
You've got to know what it is that's out there. The bottom line is that annual mammograms help detect breast cancer early and improve the chances that it can be treated successfully. However, like most medical procedures, there are risks as well as the benefits. On behalf of my colleagues at Hispanocare, Advocate Illinois Masonic Medical Center, Dr. Kirshenbaum, thank you. Section Chief of Imaging Center at Illinois Masonic, thank you for being on the show. Thank you, Illinois Masonic, for providing and supporting affordable, accessible, bilingual, and bicultural health care to Chicago's community. My name is Lucy Aquino, Chief Executive Officer of Hispanocare, and I represent Hispanocare and Illinois Masonic. Thank you for watching Can Take Cable 21. Until next time, please stay tuned. A lot more information coming your way. We'll see you soon. Have a good evening.
Thank you.
Thank you for being with us.
Thank you.
Thank you.